Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami. Welcome to Monday afternoon Instagram chat. Today's topic is IVF. Why is it so successful? And when couples are trying to get pregnant, you often hear about in vitro fertilization. And oftentimes when you meet people and they've been pregnant, and a lot of people have been on fertility drugs or other things, but IVF has become the hallmark of infertility treatment. Now, in vitro fertilization is a process where you're extracting the eggs from the woman's ovary, fertilizing those eggs in a dish with a process called intracytoplasmic sperm injection, where you take a single sperm and inject it into a single egg, allow fertilization to occur, and the embryos to then develop over the next 5 to 6 days. At the end of that time period, the one cell is divided multiple times, so you end up with an embryo that's called a blastocyst, and under the microscope it looks like a little soccer ball. It'll have between 50 and 70 cells in it, and that's a nice healthy embryo on day 5 to 6 of development. That embryo can then either be transferred back into the uterus, or it can undergo a process called pre-implantation genetic testing, where the cells on the outer surface of the embryo are biopsied, the placental cells are biopsied, and they're sent for genetic testing, and the embryo is frozen. And then once we get the genetic testing back and we know we have a normal embryo, we can coordinate that embryo to go back into a patient's uterus. So when do you do IVF, and why does it work so well? If you compare insemination success rates for unexplained infertility or mild male factor or tubal disease, IVF success rates with a normal embryo are going to encroach 50%, whereas insemination rates are going to be at single digits, basically, 8% with Clomid as an ovulatory drug. So why does it work so good? So remember, for pregnancy to occur normally, the egg has to ovulate, the tube has to pick up the egg, the sperm that are ejaculated in the vagina have to swim up into the cervix, into the uterus, into the tube, find the egg, fertilize it. The tube then has to transport that embryo back to the uterus, and the embryo then implant. So all these different steps have to happen in order to have that embryo implant and then develop into a baby. When you're doing IVF, you're bypassing all of that except for the implantation process. So you're bypassing any issues of ovulation. You're bypassing any issues of sperm function. You're bypassing the issue of, will the sperm swim up there, find the egg, fertilize the egg. You're bypassing issues of early cleavage development, your initial cell division of the embryo, because you're actually watching it in the dish happen and only considering transferring the embryos that have been successful in that very early stages. You're bypassing the issue of transportation, where the fertilized egg has to then be transported by the tube back to the uterus. But the implantation process has to work, whether that implantation process occurs naturally or whether it occurs as a result of insemination or results as IVF. So the big advantages with IVF are we jump straight to the embryo phase. So we know we have embryos to work with. And if you have embryos that have been biopsied, we know that the embryos that are biopsied are what we call genetically competent. The embryos that develop when you do pre-implantation genetic testing, the only thing you can really test for in that case is does it have the correct number of chromosomes present, or in some cases, or a big chunk of a chromosome absent. So if you look at the incidence of aneuploidy in patients, which is the percentage of embryos that are abnormal, you can have a normal egg and a normal sperm, and they get together and they start to divide. And whether this occurs on a natural cycle, insemination cycle, or in addition an IVF cycle, a certain percentage of embryos just aren't going to be normal. So that if you look at somebody who's 30 years old, most of the embryos that form are good quality embryos. They're genetically competent embryos, and 70% of them are going to fall into that category. Whereas if you look at a woman who's 40 years old, it's going to be the opposite. 70% of the embryos are going to be abnormal. In somebody who's 35 years old, we're going to see on average a split with 50% of embryos being normal, 50% is abnormal. So if you have an abnormal embryo and it gets to the uterus, what happens to that embryo? Most of the time that embryo just won't stick. Some of the time that embryo will stick but stop developing after a few more days. And even if it does stick, most abnormal embryos will miscarry. And very few abnormal embryos actually result in a bad baby. The one everybody always thinks about is Down syndrome. And the risk of Down syndrome in someone 35 years old is about 1 in 350 live births. So it doesn't occur very commonly because most embryos do miscarry when they are abnormal. And most people should have genetic testing, particularly if they're over 35, to make sure that their embryo is healthy, that the fetus is healthy. So the reason IVF with embryo biopsy and transfer of a euploid embryo is so successful, that we get that 50% pregnancy rate, or sometimes a little better in younger patients, is because we bypassed all the factors that can cause infertility, and we screened out the embryos that aren't normal. So if you ovulate naturally on your own, that could be a good egg or not a good egg. It's usually a mature egg if it ovulates, but it doesn't mean that the sperm found it. It doesn't mean that the sperm fertilized it. But when you have it in additional laboratory, you can make sure that it fertilizes. So how do you do IVF? IVF has multiple steps. The first step is producing lots of eggs. And to get lots of eggs, instead of just producing one egg in a cycle that happens naturally, we use injectable fertility drug. And the fertility drugs are meant to stimulate the ovary so that instead of producing one egg in a cycle, which is what happens naturally, we try and get actually 15 or 20 of them if we can. Now, if you're 33 years old with good ovarian reserve and you have 2 ovaries, that's often a doable goal. However, if you're 38 or 39 years old with diminished ovarian reserve and the ovary is not very responsive, then even in using higher doses of fertility drugs, we often won't get 15 or 20 eggs. We still try and get as many as we can. And the reason that we try and get as many eggs as we can within reason is that not every egg is a good quality egg, and not every egg that is mature that we inject with sperm will fertilize, and not every embryo that initially forms, meaning a fertilized egg, not every one of those will continue to develop. So because of this, the more eggs we have, the better number of good quality blastocyst embryos that we have. And as I've said previously, a percentage of those embryos that look great under the microscope on day 5 or 6, you look at them and you go, oh, these are beautiful, these should work a baby every time. And you find out that a lot of them are abnormal. So what an embryo looks like under the microscope on the 5th day does not translate into whether it has normal genetics or not. The most important thing is, the 2 most important things are, one, that the genetic complement is what's called euploid or satisfactory, meaning it has 46 chromosomes, and that it has a good morphologic development. It looks like what it's supposed to on the 5th day of development. If we put those embryos in, we're going to have pretty good success rates, and because of that, we recommend only transferring a single embryo with a frozen embryo transfer cycle. If you're doing embryo biopsy, we're obligated to do frozen embryo transfers, and one of the big questions over the last few years has been which is more successful, a fresh transfer or a frozen transfer. And in general, if you look at overall success rates that are published nationwide, frozen embryo transfers seem to overall have higher success rates. embryos that have been biopsied will always have a higher success rate than embryos that not, particularly in older patients, because at least we know we're putting back normal embryos. In our program, we don't feel it's ethically correct to transfer embryos that we know are not normal in genetic complement. In a fresh cycle, you can also get very good success rates, but you have to be careful that the lining of the uterus has not been affected by the stimulation process. Normally in a regular cycle, when a woman ovulates, they produce one egg, they have hormone levels with estrogen values of around 300, and the progesterone level will start to increase very minimally right before the signal of ovulation occurs. And that's what you normally see. That sets up a stage for a nice endometrial development in the second half of the cycle, and the changes that take place within that lining to allow an embryo to stick. And there's only this 24-hour window of implantation where sort of the Velcro of the uterus is compatible with the embryo so that the signaling between them is satisfactory so an embryo can successfully implant. So it's very important to get that timing right. And in what can happen with a stimulation cycle, when we're trying to get lots of eggs, in the process we succeed in getting a lot of eggs, but many times when we have a lot of eggs, we have each of the follicles, each of the cells that surround the eggs that normally make progesterone. A lot of times we have a lining in the uterus that's been exposed to very, very high hormone levels and a premature exposure to progesterone. And the timing for this window of implantation is dependent on an initial estrogen priming of the uterus and then a limited predictable number of days of progesterone to know when what are called secretory changes that take place in the microbiology of the cells that line the cavity that allows an embryo to stick. And what happens if you start producing progesterone too soon, then the lining matures too quickly, and when you go to put an embryo back, the lining is out of sync with the embryo. So from a practical standpoint, if you're doing embryo biopsy, we have to do a frozen embryo transfer because it takes a week to get the results back after we do the biopsy, and there's no way to keep that embryo available and live during that period of time. We'd be out of that window of implantation. So when you do a biopsy, you automatically do frozen embryos. In general, in patients who are overstimulated, we do better with frozen embryo cycles. If you've had a medium stimulation and at the time in the middle of the cycle, the progesterone level at the time of what's called HCG trigger, when the decision is made to go get the eggs, if that progesterone level is low, if it's less than 1.5, and the lining is in a sweet spot, if it's between 7 and even up to about 14 millimeters in a fresh cycle, then one can consider putting an embryo back fresh. And in the Clara study that we're doing, Clara is a IVF study sponsored by Ferring Pharmaceuticals, and those patients who have entered the study so far, we're actually seeing an excellent, over 50% success rate with fresh embryo transfers with only a single embryo being transferred. So even with a fresh transfer, we can get very high success rates, but you need to make sure that you don't have premature luteinization of the lining and changes within the lining that can adversely affect an embryo. Certainly freezing the embryos and putting back frozen embryos in no way compromises the situation at all, and it does give us a very predictable way of knowing when to put embryos back in. So from an IVF standpoint, IVF is a treatment that originally was devised for tubal disease in patients where there was no way for the egg and sperm to get together because the tubes were significantly damaged or had undergone surgery and couldn't be fixed. This was the first application of IVF. IVF was then found to be helpful in patients with male factor infertility, where sperm counts were suboptimal and there were concerns whether fertilization was occurring adequately, naturally. So it became a good treatment for male factor. With the invention of ICSI, or so-called intracytoplasmic sperm injection, where you can actually get sperm from the ejaculate, or even in men with no sperm in the ejaculate but have sperm in the testes, you can take those sperm cells and inject it into the eggs and get fertilization to take place. So IVF became the best treatment for male factor infertility, particularly the more severe the male factor, the lower the sperm counts, the better IVF works. It's good for anatomic disease such as endometriosis because it allows the fertilization of the egg in a dish outside of the body, and we know that the fluid that's in the endometriosis that floats around the peritoneum can have an adverse effect on embryo development when you test that in culture. And then obviously the last area is unexplained infertility. When we don't know why people aren't getting pregnant, IVF seems to work equally as well. Great question by somebody is, if we put a normal embryo into a normal uterus, why is success rate only in that 50 to 60% range with IVF? You would expect it to be 100%. And the answer to that is because there are aspects of the implantation process that we don't fully understand, and there's an answer to the question, but we don't know what it is yet. We know we put the embryo in the right spot, but we're limited to the things we understand now about the physiology of implantation, which is very poorly understood, and the physiology of embryos. We know that by testing embryos, we can at least select genetically a competent embryo that has the potential of working, rather than if we put back an embryo that we know had an abnormal genetic complement, it would have a very low chance of working. So if we put back an embryo that, let's say, had an extra chromosome 22 and 15, it would have extra chromosomes. That has never been a baby born with that chromosomal complement. Before we knew genetic testing, before we did genetic testing, we used to do that all the time. We put back an embryo, they wouldn't work, they were beautiful embryos, we go, we don't know why. Now at least we can filter out those embryos that are at least genetically abnormal, put back normal ones, but it's a great question is, how come a normal embryo doesn't stick into a normal uterus when everything is normal? And it's because we just don't know what to test for yet or how to test for it, and these are the things that are being looked at in academic research to try and better understand what occurs during implantation so that we can make implantation more successful. Should a polyp be removed before transfer? Absolutely. There's no really good studies on IVF patients, but there was a study published on intrauterine insemination where people were known to have polyps, and they treated them with fertility drugs and inseminations, and they found some people got pregnant even with the polyps there and some did not. They then got rid of the polyps and retreated the patients in the same exact way as they did before the polyps were removed, and lo and behold, the pregnancy rate was twice as high once the polyps were removed. So they haven't done the study with IVF because it's so much more expensive a procedure, it's sort of unethical, but the implication is that the success rate is going to be compromised in patients with IVF if there's a polyp in the uterus. Similarly, if you have a dilated fallopian tube, a hydra salpinx, then it's the same scenario, is that the fluid in the tube can leak back and make it harder for an embryo to stick. So, one of the things that we look at before we do IVF, we want to make sure that the patient has a normal uterus. That's done by ultrasound exam and either a saline infusion sonogram, hysterosalpingogram, or office hysteroscopy. We want to make sure the cavity is normal. We want to make sure there's not a fibroid or anything, scar tissue or polyps or anything that's going to prevent it from working. In patients who've had recurrent failures of embryo implantation or miscarriages, there are some other tests that we can look at to look at that particular question. Other questions? When a woman freezes her eggs, IVF is what is used to get pregnant. The answer is yes if you're using the eggs that you froze. Most women will freeze eggs when they're young. Some women won't use those eggs, some of them will. If you froze your eggs at, let's say, age 32 or 31, and now you come back and you're 37 and you're ready to get pregnant, the first thing we need to look at is, okay, is there any reason why you can't get pregnant, and tell you to try on your own. And if you need IVF, or if your tubes aren't working, or if the sperm isn't good, or other treatments have failed, then we would say, yes, let's use these eggs to do IVF with. Alternatively, let's say you come back and you're 44. At that point, if you froze your eggs at 31 and now you're 44, there's no question that going straight to IVF with the eggs that you have would be the way to go. So yes, IVF is the way you use those eggs. When you use them is a matter of what your circumstances is. Do we recommend alternative treatments such as intrauterine insemination in older women? Particularly 41 was the question, but we can say that. How do you look at IUI versus IVF? And you can look at IUI as a first step, usually with a fertility drug, and then IVF if it doesn't work. In patients with diminished ovarian reserve, or in patients that are older, time becomes much more of an issue, and then it becomes more of a balance of, if we're doing inseminations for 3 or 4 months, and that may last over a 6-month period, are we doing you a favor or a disservice by not doing IVF sooner? The ovary is only continuing to go downhill as you get older and produce less and less good quality eggs. If you ask me, is there going to be a difference in my egg quality now and 2 or 3 months from now, the answer is going to be probably not a whole lot. But if you're in your early 40s and you ask me that question, is there going to be a difference 6 months from now? The answer is there may very well be. So when you have diminished ovarian reserve, it behooves you to consider IVF sooner rather than later. Remember, when you ovulate on your own, you only produce 1 egg. It could be a good egg or a bad egg. When you do inseminations with a fertility drug, you're aiming for 2 or at most 3 eggs. You're not getting 10 or 15 eggs. And if you're 41 years old, when you go to fertilize those eggs, whether naturally in the tube with the old-fashioned way or in a dish, we're going to get the same high percentage of abnormal embryos. So the more eggs we have, the better chance one of those embryos is going to be normal. I bet one way to look at it is if we are able to retrieve a dozen eggs that are good quality eggs, that's equivalent to having a year's worth of ovulation or a year of exposure all in one IVF cycle. How long does IVF cycles take? The actual fertility drug part is 10 to 12 days before the eggs are ready to be retrieved. The process really occurs over a 2 to 3 month window, in that once all the basic stuff is done and we're ready to go, we'll get you on fertility drugs that you take for between 10 and 12 days usually. During that 12-day period, you're monitored with ultrasounds and blood tests to see where we are in the development of the follicles, which are the lakes where the eggs live. And then we know when to retrieve the eggs and when to consider getting them to do IVF with. Once we get the eggs, they're fertilized. We get sperm from your partner, and then you let the embryos develop for 5 to 6 days. The embryos can be transferred at that point, or biopsied and cryopreserved. If they're cryopreserved, then they would go back a month or 2 later. So if it's all done in a fresh cycle, the whole thing takes 3 to 4 weeks. From when you start to when we know you're pregnant is usually 4 weeks. If we're freezing embryos and doing embryo biopsy, that 1 month can become up to 3 months, basically. So that's IVF in a nutshell. It's a great way to treat patients. It's not always the first way to treat patients. It is with severe male factor, it is with tubal disease, it is with diminished ovarian reserve, but it always has the better success rate. It's going to depend predominantly on the quality of the eggs and the quality of the embryos. Once the embryos are transferred into a uterus, our recommendation is just take it easy for 2 days, be a modified couch potato, let that embryo implant, and eat well and be normal. So have a good afternoon. Think about IVF as part of your treatment. Please ask your doctor if now's the right time, or do I want to try other things first, or am I better off going directly to IVF? And we'll be happy to guide you, and hopefully we're both on the same team. We want to get a healthy baby and see you guys pregnant and back to your OBs. So have a good day, stay safe, and have a great afternoon, everyone.